So, moving on to the genetic disorders causing jaundice, like Gilbert syndrome, Dubin-Johnson syndrome, Crigler-Najjar-Rotos syndrome. So, first, let's see Gilbert syndrome. In Gilbert syndrome, the problem is UDP glucuronidase transferase (UDP-GT) enzyme has reduced activity and also due to reduced uptake of bilirubin. So the bilirubin is not going to be taken up by the enzyme UDP glucuronidase transferase and it's not going to be converted to bilirubin glucuronide. So conjugation is a problem. So what do you think is the bilirubin going to be increased? That's right. The unconjugated bilirubin is going to be increased. It is an autosomal dominant disorder. Serum bilirubin level is usually less than or equal to 4 mg per deciliter. So it's like just enough to cause the jaundice. As we already know, for making the jaundice visible, the serum bilirubin should be like 2.5 to 6 mg per deciliter, which is why. So, like Gilbert syndrome is a very common disease. It's like Albert. Albert is a very common name. Gilbert is a very common disease. And then, so we don't need specific treatment. The patients have normal life expectancy. And then we have a provocation test specifically designed to diagnose this test or something. The serum bilirubin level is going to increase during any sort of stress or fasting. So that is the provocation test. So treatment phenobarbital administration normalizes the serum bilirubin level. However, most of the patients need no treatment. Like 8% of the population have Gilbert syndrome and show no symptoms basically. So you don't have to necessarily treat this disease. Okay. Okay, so that was about the Gilbert syndrome. It is due to reduced activity of UDP-GT. Okay, done. Let's go to Crigler-Najjar syndrome. So, like Crigler-Najjar syndrome is of two types, type 1 and type 2. Type 1 is due to complete absence of bilirubin UDP GT activity. Okay, completely it is absent. The activity is absent. It is an autosomal recessive disorder. It is found in neonates. It is characterized by severe jaundice, and here we are looking at a number of more than 20 mg per deciliter. See, for a normal jaundice to just be visible, the level which is necessary is 2.5 to 6 mg per deciliter. But here it's what? It's like 4 times above 5. So it's 20 mg per deciliter or more. So like kernicterus is going to develop, and then this kernicterus is going to lead to death in infancy itself. So obviously the goal of the treatment is going to the target of the treatment is going to be to keep the bilirubin level under 20 so that kernicterus does not happen, so that the child does not die before any definitive treatment is suggested. Okay, so this is like the first treatment. So this disease, the Crigler-Najjar type 1, is going to present 1 day after birth, immediately, like it's almost like immediately, right? 1 day after birth. They usually do not survive and die as soon as birth due to kernicterus, or like life expectancy is a maximum of 18 to 24 months without any treatment. Crigler-Najjar syndrome type 2 on the other hand is due to reduced activity of UDP-GT. It's not like complete absence, it's reduced activity. Okay. So like it's reduced to 0 to 10% of the normal, but like 10 to 33% of the activity was there in case of Gilbert syndrome, 0 to 10% in case of Crigler-Najjar type 2, 0% activity in case of Crigler-Najjar type 1. Okay. So the type 2 disease is autosomal recessive. Type 1 was autosomal recessive as well. Okay, Gilbert syndrome was dominant disease. Both Crigler-Najjar syndromes are autosomal recessives. Serum bilirubin level are in the range of 6 to 25 mg per deciliter. So here also we are looking at a big number. Okay, so the patients usually survive into adulthood. Kernicterus is uncommon, but again may develop under the stress. For example, under the surgery or intercurrent illness, then the person will develop kernicterus. Serum bilirubin decreases by more than 25% in response to enzyme inducers like phenobarbital. So like phenobarbital is also helpful to reduce the jaundice, but again phototherapy, exchange plasma exchange transfusion, plasmapheresis, these are all like the treatment. Phenobarbital therapy is useful, but however in case of like Crigler-Najjar syndrome, the definitive treatment is going to be what? Obviously liver is crude liver transplant. Okay, so we're gonna like look at the contrast in the next video because it's gonna get over. So like, okay, thanks. We saw Crigler-Najjar syndrome and also Gilbert syndrome. Okay, that's it.